Hi, my name is Rónán O'Caoimh. I'm a geriatrician in Cork City in Ireland, and I'm going to talk today a little bit about how to develop a remote virtual memory clinic. I suppose I'm going to describe a little bit around the journey we're just beginning to start in the setting of COVID-19. Our memory clinic is based in St. Finbarr's Hospital in Cork City. This was originally opened in the 1840s in Cork City as its first workhouse. And the campus has transitioned over many years, over the last 150 years or more, to develop a number of off-site day hospital activities. And part of this campus, we have our assessment and treatment centre, and we have 2 memory clinics that run out of the assessment and treatment centre. So these provide a general memory clinic and also a specialised diagnostic service, predominantly focusing on those with early stage cognitive impairment, mild cognitive impairment. So the memory clinics are backed up by a team, a multidisciplinary team, which includes physiotherapists, occupational therapists, speech and language therapists, and a number of nurse specialists as well, advanced nurse practitioner. And they link in with existing services on the campus, including a memory gym, an on-site Alzheimer cafe, and our caregivers training support program as well. So the clinic sees about 300 to 400 patients per year. This is results for the general memory clinic. And again, as you'd expect, half of these patients have dementia. The median MoCA score for this population is about 20. Most are female and they're aged mid-70s on average. So I suppose before we began developing this service, and I'd have to say it's at a very preliminary stage, but we did look to see what evidence is available out there already. And most evidence is from countries with large terrains, so big geographic areas with relatively small, sparsely developed populations. And I suppose the goal is then to try and provide uniform care across those settings, and telemedicine and remote healthcare seems to be one option for these. So in Canada, there is one example, I suppose, of how to develop a remote memory clinic. It's a hybrid model, so it isn't just virtual clinics, but they operate this with a combination of on-site visits as well. So it starts off with a pre-clinic assessment, which is telehealth related. That can be telephone conferencing or video conferencing, about 30 minutes with a nurse, a neuropsychologist, and they have a very standardized assessment that goes with this. It's a pre-assessment before patients will come to a face-to-face on-site unit. They can request bloods to the GP, link in with the GP during that pre-assessment period. And then patients come for this one-stop MDT assessment where they can get neuroimaging, and there's case conferencing, and GPs are included in this where possible as well. And I suppose follow-up then over that period can be mixed, it can be flexible, it can be delivered predominantly remotely through video teleconferencing, or can be delivered in person as well if the patients require it. South of the border in America, the American Medical Association described, I suppose, in detail how one would start off and develop a telemedicine program. And this could be adapted for memory clinic populations as well. I suppose predominantly it's about setting up a core working group, establishing who the key stakeholders are, understanding what is involved in this, both from a practical clinical perspective, but also from an IT perspective and a risk management perspective as well. So linking in clearly with your hospital management and with other services within the hospital setting. And I suppose then, it's about setting up the service in a patient-focused way. So trying to link in with patients to find out what they want from the service, providing education to staff, setting up the expectations. So early goal setting, understanding what would be a good outcome and what would a good model look like for your service in particular. And then over time, I suppose it's about setting up those models and developing them in an iterative fashion where you can cycle back and re-examine how the model is working. So in Cork, we've only had a number of weeks of these virtual clinics, and there's been a number of issues that we've identified. Solutions for these are something that's in progress at the moment. We have begun to work towards them. Communication was the main issue that we identified early on. The COVID-19 crisis in particular has created, I suppose, a deficit of information and maybe an oversupply of other types of information as well. Patients are often very concerned about attending a clinic setting or in a hospital setting, and it wasn't clear which clinics had been cancelled, which clinics hadn't been. So we, I suppose, set out a standard letter to send to patients, provided a contact number for them, and contacted patients where appropriate as well. We then needed to prioritize the patients that we felt had to be seen, or patients that really would benefit most from this service. So we reviewed all upcoming clinics kind of 2 weeks ahead of schedule, and that's the way we've operated so far. So we do a chart-based review. We go through the patients and select those who are most likely to benefit from a virtual clinic model, and also those that I suppose need to be, make contact with as a priority. Then we have this triage system whereby we phone each of the patients in advance of the clinic, a little bit like the Canadian model I described. We can make contact with the next of kin and with the GP as well, and get some information on the background and on the current status of the patient. The patients we've seen so far have all tended to be follow-up patients, so it's, we have a baseline information on them, and a lot of it is around getting an update as to where the patients are at the moment. We run afternoon slots, but 1 hour apart. We find that probably works the best. It allows us to have a debrief before and after ourselves to understand where the patient is at the moment, and then to reflect on the clinic appointment as well. One of the biggest challenges has been around remote cognitive testing and how to screen and assess patients reliably at home. For follow-up patients, because we know where they're at, sometimes there isn't that need to do regular cognitive testing, but for those where their next appointment is perhaps their second appointment with the service, it is important to see, has there been any change since they were last seen. So we have had to look into this in a little bit of detail, and we've done some literature reviewing to look to see what instruments are suitable for remote cognitive testing. And there's a number of telephone-based screening tools which are available. So there's a publication a number of years back which identified 19 different instruments that are being used. About a quarter of them have been externally validated, so there isn't great evidence behind any of the instruments. The most widely used instrument is the telephone interview for cognitive screening, which seems to have the most evidence behind it. But there's a number of limitations with these instruments, and as you would expect, a lot of it is related to the lack of being able to control the setting in which the testing is happening. So good cognitive screening, for it to be reliable, to be accurate, does require one to be able to control the environment, that the lighting conditions are correct, that there's no distractions for the patients, that their hearing aids are present, that their glasses are on, all these sort of things that help control the performance. It's also difficult, I suppose, to really understand if anybody's present, if there's prompting going on, if patients are writing details down. Some of the tests would include delayed recall tests, and it's not clear whether the patient has taken the opportunity to write down the list rather than actually trying to remember it. So it does present some challenges. There are a number of instruments that we posted out as well in advance of the clinic appointment. So there's the Test Your Memory, which was published just over a decade ago and has good evidence base behind it. But again, it was a test that was designed to be performed in a clinic setting where the patients could be kind of left to complete the test while waiting to be seen by the doctor, rather than something that was designed to be sent out by post. We have developed a caregiver memory test ourselves locally, which we have begun to post out to patients in advance of clinic. We've done that over many months before this, and we've been fortunate to be able to utilize some of these tests. These are screening tests that are done with the patient prior to admission, and include orientation, verbal fluency, and logical memory testing that can be done remotely with support by a caregiver if the patient has a caregiver available. And we did a brief survey looking to see whether patients would find this acceptable, and most found it easy to use and were happy to use it again. So this is the model that we are beginning to move towards. So rather than the traditional clinic-based appointments, we are taking any referral letters from the GPs or any upcoming appointments. We're triaging the letters and the charts, linking with their primary care provider or the ED physician if that's where the referral came from, and then linking with the patient as well. A triage pre-assessment is then performed, and that leads on then to the virtual clinic appointments. After this, some patients will need to be seen in person, and I suppose we have a COVID-19 checklist of questions that we would ask, and if those patients, screen positive for that, we would refer them back to their GP or to ED, depending on the symptoms or where the patient's referral has come from. And if not, then there is an option for a clinic appointment visit, and if that's not acceptable to the patient, then a home visit can be organised as well. So we're very much at an early stage in this. We've only had 2 clinic appointments so far, and a small number of patients have been seen. They've all been follow-ups. We're not sure about the practicalities or the ethical nature or the requirement to make a formal new diagnosis of cognitive impairment remotely. I suppose we hope this will be a temporary crisis, and it's not clear whether this virtual model will persist beyond this. But the principles of offering flexible clinics to patients and the enhancements that new technology will bring to this is something that potentially could last beyond this crisis. There's lots of learning that can be got from it. Trying out these new models of care is something that is a unexpected, I suppose, bonus of this crisis. So that's it. Thank you very much.
I think that one question that arose for me was that, yes, it's early days and you've not had many patients go through this process, but in terms of the caution and the caveat to giving a diagnosis of dementia from a remote assessment, do you actually give the diagnosis, or do you say it's probable, and would you reaffirm that on a face-to-face basis? Because it is quite a diagnosis to give somebody if then in a face-to-face situation you might not have done.
Yeah, I mean, look, it hasn't come up as an issue so far. It has been more monitoring activities rather than diagnostic activities, and staging patients over time. A lot of it is reassurance. They have a lot of questions around COVID-19 in particular. There have been challenges in relation to healthcare staff, particularly home helps in the community, reduction in home help hours, not for financial reasons, just due to staff availability. So that's been really a big challenge. And they're the issues that seem to have come through most so far. Getting back to your point, I suppose the ethics of giving a diagnosis remotely, it is a difficult diagnosis to give. There's a lack of certainty. And a lot of it is about, as you know, monitoring over time and seeing how the condition evolves over time. So again, in any single snapshot, we don't tend to make that diagnosis. But if we'll say this was something that was running over 6 months or a year's time, I suppose, one would hope that there still should be that flexibility within that model to try and bring people in for that face-to-face. I think, as with any diagnosis of a condition as serious as this, whether it be a cancer diagnosis or other, it is important to actually be present in the room to actually make that connection with somebody. I personally don't think I'd feel comfortable with doing that remotely like this, particularly when you're talking about a generation that just aren't used to technology in the same way. And most of these patients are older patients. We tend to see mainly a geriatric population in our clinic. So I don't think that's something that would be feasible, I would say. I think if you were to talk about people maybe at an earlier stage, maybe younger cohorts, people with mild cognitive impairment in particular, I think it could be more practical to give advice there around that remotely. And one could certainly prepare somebody for that type of diagnosis remotely as well with these kind of conversations. I guess, it all depends on the circumstances. We hope this is something that's temporary and that will pass, and that, this could be used to try to maybe build up knowledge about the patient and I suppose reassure, at least, if not diagnose, in the initial phase as a preparatory phase. And generally we found, whether it be dementia or other aspects, actually the telephone or telehealth connections do actually help patients. They reassure people that people are still there, that doctors are still, nurses still available. I'm sure through your own work as well, I'm sure making contact with patients by phone probably much more frequently and routinely, you probably see that they actually do value that as well, you know.
Well, certainly I was talking about the Admiral Nurse telephone helpline. So we've got a distinct group of Admiral nurses who are very familiar with this method of contact. One of the things I was talking about was how increasing the confidence and skills of those nurses that are used to the face-to-face community-based work. And that might be the case for you with the memory clinics also, that it's a very different way of practicing, not just of how you conduct yourself on screen, but how you have to be attuned to what you're hearing or what you're seeing,
Yeah.
rather than, you know, what you're physically experiencing in a scenario. So what's the confidence levels of memory clinic staff in doing this?
Yeah, I mean, it's been mainly doctor-led, and I think, you know, because it's been exploratory a little bit, you know, we haven't had that time to get feedback from the staff yet. I was even talking to them today, and one of the occupational therapists, you know, she said the whole world is kind of up in the air and everything has kind of been left to fall down onto the ground, and we're seeing where things are at. And I can appreciate where she's coming from. And nevertheless, you know, I think she did feel that there was a benefit in calling people in just catching up with where they are at the moment, you know. I think it's easier with people that you maybe have a therapeutic relationship with already.
Yeah.
It's a little bit more challenging if it's somebody who you're meeting for the first time, you know, by phone or by video link. It is a different experience. So far, because it's been early in this, I think people, they feel comfortable enough with it because they feel like they're speaking to people they know. They've had that relationship before. They've met face to face before, and that they're making that link, not to, you know, break news or to give a diagnosis or to make a diagnosis, but more to kind of monitor and see how people are, how they're coping, how they're adapting, what challenges they have, and if there's anything they can do for them, you know. It's almost like a hug in a way, rather than necessarily, you know, being something that's practical, you know.
I don't know about you, but in a way, a positive aspect to working differently like this is that we're between a rock and a hard place, so we have to get on with it. So in a way, that gives you permission not to procrastinate. Like you were saying, doing literature searches, you try and make it the best approach that you possibly can on the best evidence. And everybody's almost like scrabbling around looking for the holy grail of evidence in COVID at the moment. But you have to break new territory sometimes, and you just have to give your staff and yourself permission to go for it.
Yeah, absolutely. It's trying new things, and you know, some things may not work very well, and you just have to maybe just go back to the drawing board very quickly and start again. And you're right. I think in this, you know, if anything, it's given people a lot of freedom to try new things that we've always talked about initiating, you know. Well, you know, memory clinics may not be the best place to do this work. In practice, you do see from other sites, other countries where they have to do this sort of activity, that it does work very well, you know. So, well, it's a necessity here for us, you know, at the moment. You know, its practicalities will no doubt, you know, change the way we practice on a regular basis.
Very interesting when all this is over, what we decide that we keep going in terms of different ways of working. I don't know about you, but even in clinical meetings or team meetings, do we really have to get 20 people face to face? Microsoft Teams is excellent. So that I think that we will all probably reflect on this time and think, have we been working in the most effective or efficient way? Are there things we can do differently or should still do differently?
Yeah, no, it's very true. It's very true. And particularly for people who maybe have disabilities, people who are challenged with coming into a clinic setting. So I mean, we operate clinics here, but we also operate them in the city centre, where the acute hospital is as well. And, you know, I see memory patients there as well. And, you know, it's a much different experience for them than even coming here to where it's a big campus. There's plenty of room for people to park their car. There's good disabled access. In the city centre, that's just not the case, you know. And there's a lot of arguments to be said that there are many patients that don't benefit from coming in at all to be seen, you know. There probably is that need for face-to-face initially, but then if you're following people over a period of time, you know, with families, you know, available, with patients themselves, you can actually provide an awful lot of support to them remotely. And they probably get as much out of it in a lot of ways as they would by a face-to-face, you know. I think it'll be good to talk to patients and see what they think of it as well, because, you know, when it is different, it's new, you know, some might feel very comfortable with it, some might feel very uncomfortable with it. And maybe it's about getting the right, you know, the right model for the right patient. And, you know, older people, you know very well, they're so heterogeneous in their approach to everything. Some are very much IT savvy, tech savvy, and love embracing new technologies, and other people, they've never even heard of these things and they mean nothing to them. And it is about kind of a little bit, you know, stumbling, trying to see what works well for each patient. And I think we do that in practice anyway with most of our patients. This is just making it very, very obvious, I suppose.
Great.